Thank you very much, AJ, and good afternoon, everyone. I'm very pleased to be here. The topic that I'm going to address is the treatment of low-risk patients with non-valvular atrial fibrillation. I also have to declare some conflicts of interest, and here they are. You should read these and understand them before I continue. Let me first describe the objectives of this research that I'm about to describe. We want to describe the baseline characteristics of patients at different levels of stroke risk, conforming to guideline recommendations. We want to evaluate the treatment patterns in these patients at different levels of stroke risk. And thirdly, we'd like to analyze the one-year rates of clinical outcomes of stroke and systemic embolism, major bleeding, and all-cause mortality by their risk category and anticoagulant therapy. This cohort consists of almost 40,000 patients followed for almost 1 year. There were some 537 strokes or systemic emboli, 328 major bleeds, and an all-cause mortality number of 1,603, and you can see the corresponding rates, 1.4 for stroke, 0.9 for major bleeding, and 4.3 for all-cause mortality. The ESC guidelines, released in 2012, considered patients at risk according to the CHADS-VASc scheme, and illustrated on here are the patients who were considered for anticoagulation. That was men with a CHADS-VASc score of 1, and those who were recommended for anticoagulation, both men and women with a CHADS-VASc score of 2. The guidelines which will be presented tomorrow and which are available today in the European Heart Journal are a little different. Now recommended for anticoagulation are men with a CHADS-VASc score of 2, as before, but women with a CHADS-VASc score of 3. And those considered for anticoagulation include men with a CHADS-VASc score of 1 and women with a CHADS-VASc score of 2. The Garfield high-risk group are men with CHADS-VASc score of 2 or greater and women with a CHADS-VASc score of 3 or greater. It's the same group as the ESC recommends for anticoagulation. And the Garfield low-risk group are all except the high-risk group. Given these recommendations, we can divide the population of Garfield into those that have never been recommended or considered for anticoagulation according to guidelines, men with a CHADS-VASc of 0 and women with 1, a group that were considered for anticoagulation in ESC 2012, men with a CHADS-VASc of 1, a group that were considered for anticoagulation as of the guidelines operational for tomorrow, men with a CHADS-VASc score of 1 and women with a CHADS-VASc score of 2, a group that are now considered but not recommended for anticoagulation, women with a CHADS-VASc score of 2, and then those recommended for anticoagulation in 2012, a score of 2 or more in both men and women, and those recommended tomorrow for anticoagulation according to the ESC, men 2 or more and women 3 or more. Looking at these groups arranged along the horizontal at the top, we can look at the demographics of these groups on the categories shown on the vertical. You can see to begin with that some of these groups are not large. For example, the do not anticoagulate group and the group that were considered but not now recommended for anticoagulation. As the risk category increases, of course, the age increases, the proportion of paroxysmal atrial fibrillation decreases, the proportion of permanent atrial fibrillation increases, and the presence of comorbidities is by definition at high CHA2DS2-VASc score much greater. Looking at the actual CHA2DS2 score, CHA2DS2-VASc score, and HAS-BLED scores, you can see that as the risk increases, it does so according to the CHA2DS2 score and the CHA2DS2-VASc score, moving from 0, of course, in those that are not anticoagulated, to 2.1 and 2.2 in the two groups where anticoagulation was recommended. The CHA2DS2-VASc score also increases up to 3.6 and 3.7, and the HAS-BLED score goes from 0.4 in those not recommended for anticoagulation to 1.6 in the two groups that are recommended for anticoagulation. The treatment patterns for these groups are displayed on this slide, and you can see on the left-hand side the lowest risk group. Surprisingly, anticoagulation is used in approximately 45% of this group, despite the fact that they are not recommended for anticoagulation, but of course does include some patients perhaps who were scheduled for cardioversion or ablation, something of that sort. Then there is a group at low risk who are anticoagulated at a rate of about 55%, and then the two groups that were recommended in 2012 and 2016 for anticoagulation, who are anticoagulated at a rate of approximately 67%. If we look at outcomes now, we can see that the event numbers are very small in those who are not recommended for anticoagulation, as you would imagine. This is for stroke and systemic embolism. Also relatively small in those considered for anticoagulation in 2012 and those who are considered now but not recommended for anticoagulation. You can see that the rates are higher in those recommended for anticoagulation, and the effect of anticoagulation is difficult to see in the lower risk groups, but it is quite plain in the higher risk groups. If we move now to the 1-year rate of major bleeding, again we see that major bleeding in those who are not anticoagulated is relatively low. It's much higher in the groups that are recommended for anticoagulation, and you can see that adding anticoagulants multiplies the risk of bleeding 3 or 4 times in those who are at relatively low risk, but approximately doubles or increases by 70 or 80% those who are recommended for anticoagulation. We often do not consider the mortality events in patients who are anticoagulated. This is often because registries don't contain this information, particularly claim-based registries. But you can see here that there is a major effect from anticoagulants in those patients who are recommended in 2012 and now in 2016 for treatment with anticoagulants, but there is little or no effect on mortality in these other low-risk groups. So summarizing the situation, looking at the various risk categories on the vertical and the hazard ratios for stroke, systemic embolism on the left, all-cause mortality moving to the right, major bleeding, and a composite endpoint that includes these variables and also acute myocardial infarction. We can see that with regard to these groups that are advised not to anticoagulate or to consider for anticoagulation, that there is little reduction in stroke or all-cause mortality, a major increase in bleeding, and no net benefit. Whereas in the groups that are recommended for anticoagulation, both in 2012 and in 2016, there is a decrease in stroke associated with anticoagulation. All-cause mortality is down, bleeding is up, and so is the net benefit. So in conclusion, Mr. Chairman, ladies and gentlemen, men with a CHA2DS2-VASc score of 2 or more, or women with a CHA2DS2-VASc score of 3 or more, and men with a CHA2DS2-VASc score of 2 or more and women with a CHA2DS2-VASc score of 2 or more are both high-risk groups for stroke and mortality. Both groups are treated very similarly with anticoagulation in the Garfield AF registry. In both groups, anticoagulation is associated with lower stroke rates and mortality event rates. Women with a CHA2DS2-VASc score equaling 2 and men with a CHA2DS2-VASc score of 1 plus women with a CHA2DS2-VASc score of 2 subgroups have a lower risk of stroke, not clearly reduced by anticoagulation in terms of the one-year event rates in Garfield AF. And we certainly seem to need, from this analysis, an improved risk stratification to identify those who are at risk within these lower risk subgroups. Thank you very much.